Is that Sabrina Taylor who's joined us?
Hey, David.
Hey, how are you?
Oh, good. How are you doing?
Oh my goodness. Are you not at the office today?
No, CIT was here this week, so we were at the hotel, and I'm working from home as little as possible today.
Got it. Got it. And so the CIT conference is going to be in Phoenix.
Yeah, JW Marriott.
So tell, I know not many people are on yet, but what's the date on that? So, Sabrina, do you remember?
August 16th, 17th, and 18th. It's a Monday, Tuesday, Wednesday.
And you've got Vic Armstrong speaking this year, I understand.
We do. I'm excited. I think I have to introduce him, so I'm going to have to get some info from you.
Awesome. Terrific. So let's go ahead and get started with today's Crisis Jam. Thanks everyone for joining us. Back in January, we had a presentation and a Crisis Talk article from Nikki Highsmith-Vernick and Glenn Schneider with the Horizon Foundation, and we talked about the GBRICS project. And today, we're going to hear from the leadership at the Maryland Health Services Cost Review Commission, who are behind not only the GBRICS, but two other terrific initiatives there. So really excited about as we continue to see Medicaid and payers bring really significant investment, not just in services, but even in infrastructure that we're going to see from Maryland. So terrific. Let's go to the next slide. Thanks, Karen. And Margie Balfour, who's behind our new Margie's Crisis Meme segment. Margie is actually unable to join us. There's a tragic, Margie, I want to make sure you're not with us. Margie didn't believe she was going to be able to join us. There was a tragic shooting in Tucson that the crisis unit there is responding to. And so she's engaged in that. But Paul, we did, Margie's been great. She's got a pipeline built up for a few weeks now, but she's been trying to bring attention to some of these key issues, the same kinds of concepts that are highlighted in the Sampson National Guidelines for Behavioral Health Crisis Care. So Paul, Margie approved you channeling her meme for today.
Yeah, well, it's exciting. I think what we know is 25 years of parity law has led to a lack of payment for mental health and substance use treatment services so far. For those of you like Vic Armstrong that have never watched the Star Wars film, you don't know that all of these individuals are related, and they discover that at one time or another. But the unfortunate part of our related healthcare system is we still do not relate mental health and substance use treatment to overall care. And I know it's a push we've worked on a lot. Medicaid has come a long ways in driving this, but Medicare and commercial are significantly behind. And those of us focused on crisis care, I think we know pretty clearly we cannot get reimbursed for those codes as of yet.
Mike Hogan, are you with us by chance? Mike, you and I met with the Action Alliance, put together a meeting with top health plan leadership. Oh, that's had to be 4 or 5 years ago. Mike, are you with us by chance?
I am.
So Mike, you remember we had all of the big players there at that time, and they were interested. I mean, the best I can recall, they were concerned about the challenges that in most markets, they've got 6% of the members or 10% of the members. So how do they come together? But any reflections on this issue, Mike, of moving from Medicaid, which we're beginning to make some gains with, and getting into Medicare and third party?
Yeah, it's a slog. I mean, the central feeling that I remember from that conversation was maybe a little less positive than yours. I mean, they were definitely, happy to be there and happy to talk, but it kind of came down to nobody's asking us to do this. It's not part of conventionally what's required yet. Why don't you get back to us when there's a general expectation that this should be done? And then there were lots of details like, oh, we've just got a piece of the market. I do think that the progress is going to have to be fought out largely on a marketplace by marketplace basis. Medicare, of course, is a different ball game, and it'd be interesting to see whether any things that are happening now relating to Medicare could lead us to more of a national flavor. But other than that, I think in individual markets, Medicaid, which is going to be the primary payer, is going to have to get established, or Medicaid, get established first, and to cover, the obviously coverable services of mobile and facility-based crisis care. And then, going from that to go to, there's certainly going to be, in most states, there are going to be health plans that are involved in that. And so the health plans will begin to get used to it. And then just trying to get, as many crisis centers do now, who provide those clinical services, trying to get rates and relationships and billing established to get other payers to pay for that. But I think it's a long uphill slog.
So, Mike, even your answer, though, for me conveys movement, because if I'd asked you that question 3 or 4 years ago, I know your answer would not have been it was a slog. You would have said it's okay to want that, David. So, hey, that's progress.
I think that's right.
Yeah. Hey, next slide, Karen. Thanks. And thanks to Margie for continuing to bring, she's obviously putting these out on Instagram. And I believe a lot of the SAMHSA team is occupied today with another commitment, but John Palmieri, are you with us today?
I am. Yes. Good afternoon. Richard had the audacity to take some leave time this week. So
What?
I know.
He's still checking email once a day. This is Michelle, David. I'm on as well.
Great. Thanks, Michelle.
So yeah, just a few things from SAMHSA's perspective to provide some updates on. We are tracking the FY22 appropriations process, which I'm sure many of you are as well. And there is obviously language in there that's certainly relevant to crisis work, including proposed 10% set aside, some additional support for the mental health block grant, and some additional funding for suicide prevention investments, among other things. We are also currently working a lot, even though it's hard to believe, on the FY23 budget and appropriations process, preparing some information and analysis for that as well. I know Richard's talked about our reports to Congress for quite a few months now. We are making progress in those reports. And I know that there's been frustration on the part of many that those reports have not been turned in, but we are getting to a place now where we've been able to pressure test a lot of the assumptions and modeling in the reports. One of the challenges, as you can imagine, is that there's just constant change and moving pieces. And so when we sort of base estimates on certain assumptions and then those assumptions change quickly, right, it requires us to make some rapid adjustments. And so that's been part of the reason that there's been some delay. But we are moving, I think, much closer to the finish line there. We also are really thinking through a lot in terms of activities related to convening states and stakeholders around readiness for 988. I know there's already a lot of activity happening in that space, but really thinking about a way that the federal government can support that through different convenings and to support road mapping and implementation guidance in the future. We are doing a lot of coordination across federal agencies to develop partnerships within HHS and other departments as well, to align the priorities related to crisis services and the resources related to crisis services. And then finally, just spending a lot of time talking about and thinking about communications and what that's going to look like, starting to partner with organizations. The Action Alliance has already done a tremendous amount of work in this space, and really thinking through some of the short-term messaging and then also kind of a longer-term, broader public awareness campaign. So that's just kind of a quick update on the things that we've been involved in lately.
Terrific, John. And the Action Alliance does have its executive committee meetings today and tomorrow. John, Richard had referenced the Telecom Association wanting to put out this press release touting that 95% of cell phones already are active with 988. Do you know the status of that, whether they're going to hold off or move
No,
forward?
I believe it's out. I will get my hands on it and
That'd be great.
Get it to you.
Excellent. Thank you so much. So,
Sure.
Michelle, do you want to make any comments in Richard's stead?
I don't think so. I think John hit all the relevant points. I mean, I guess I will, and I know there are at least a few folks here that were on another call earlier this week. I think at least part of the angst around the reports, but not all of it, has been coming from states and their need to respond to Vibrant for their state planning grants. I think one thing that we have taken a careful look at SAMHSA that maybe hasn't made its way to states yet has been truly what we're expecting the volume to look like as of July 2022. I feel like I've been hearing some panic is probably a little strong, but just a lot of concern that we have these, we're predicting these large increases in volume and kind of needing to be 100% staffed and ready to go effective July 2022, when some of the analyses we've been doing have actually, been suggesting it's going to be more of a ramp up. So I'm planning to circle back with Vibrant on some of that, and hopefully they can get messaging out to states. I know there are a lot of other reasons why the reports to Congress are important to get out, but I just wanted to add that piece.
Yeah, Michelle, and that's, Ruchi Sakija on our team at RI uses the phrase healthy tension. And I think healthy tension is here, that it is going to ramp up. There's probably minute volume at this point on 988 itself. On the other hand, we should have been panicking for some time, in that we're unable to meet the volume that's already coming in on the Lifeline, much less 988 coming into play. So it's a both and
Yes,
we're certainly seeing a ramping up of unprecedented proportions. And this another healthy tension. Debbie Atkins, what you quote last week of one shot to get this right. We'll get it as right as we get it, and then we'll have to make adjustments because it's a little bit of a heat-seeking missile. So thanks so much to SAMHSA for this, so much writing on, and you guys have put so much thought and care into getting this as right as we can out of the gate. So just terrific stuff. Brian, I know we have some comments from Megan, but Brian, any comments to start from the vantage point of the states? And Karen, we can go to the next slide.
Yeah, thank you, David. Thank you for all your continued work. Also, thank you to John and Michelle and the SAMHSA support. We're looking forward to the presentation by Tequila Terry. It's real exciting what they're doing in Maryland. So looking forward to that. States continue to work on post-COVID strategies while watching for that resurgence of COVID. COVID just doesn't seem to want to go away. So we keep having to deal with COVID, but states are also trying to address what the environment, what it's going to look like after COVID. States are dealing with a primary problem of workforce shortages. They're looking at what can be done through telemedicine, what can be done through teleconferencing, what can be done through technology to meet the demands, but also looking at how to change the system to decrease the demand. It's going to be easier in many ways to do that than do a quick increase in the workforce. On the other hand, COVID may have caused many people to look at what they're doing in their careers. Maybe an opportunity for us to do a better job of recruiting some individuals that wouldn't usually have gone into behavioral health. Right. So states are looking at what they can do with recruitment, retention, new populations to attract, as well as trying to do a better job of integrating peers as professionals in their services. Now I want to quickly bring in Megan to talk a little bit about crisis services for individuals who are deaf and hard of hearing. Megan?
Brian, thank you so much. I really appreciate this opportunity. I think one of the main points I really want to get across out of the gate is that American Sign Language, which is frequently somebody who's deaf, their primary language is not English. So when communicating with somebody who is deaf, you can't necessarily text or write back and forth or think that ASL is English on the hands. It isn't. So, and ASL is a big cultural main piece of being deaf. And there are lots of other cultural pieces that are so important to understand. So for example, if somebody has to be transported, communicating how long will it take to be transported. If for some reason there's some law that their hands have to be bound, that makes them like they're gagged. They can't communicate. They can't say they have to go to the bathroom. They can't say anything and they don't know what's going on. So it's really, really important to understand even those beginning nuances, as well as bringing in the deaf community as you establish your crisis services. And if you have them far along, please, seek that voice. Crisis services are also a wonderful opportunity to create deaf peer support services. With the Crisis Now model, with 50%, up to 50% being peers, developing a deaf peer support system would be excellent. Thank you.
Wow, really terrific comments, Megan. And Megan, I know that we had we were working to schedule a meeting with some leadership who could bring more, even maybe do a featured presentation. Did that get scheduled, or are we still working on that?
It's on Friday.
It's on Friday. Terrific.
Yes.
So it'd be great to bring more attention to this as we move forward. Thank you so much for your leadership in this area, Megan. And Brian, the issues of workforce, there was just a major article in Modern Healthcare. This is a broader healthcare challenge, not just for behavioral health. For any of you on the call who have subject matter experts or thoughts around this issue of workforce, Brian, it would be great for us to do a featured presentation on that issue. I know we've teased at that a bit. And Brian, finally, we're going to talk Maryland today. How long were you the mental health commissioner there in Maryland, Brian?
13 years.
Yeah.
13 excellent years. Really
terrific,
good,
terrific.
really good system. And HSCRC, the rate commission in Maryland is fantastic.
Awesome. Let's go to the next slide, Karen. NASBIT has been so critical in bringing Office of Behavioral Health Leadership to the table so that we have all 50 states are involved in this learning community. And again, we've been adding Medicaid representatives week over week. Sometimes you're outreaching someone from Medicaid to join us, and sometimes there was already someone from Medicaid on the calls and we had not recognized them as such. So again, if you're in one of those blue states, we've added several over the course of the last few weeks. We're up to 10 now. If you have Medicaid leadership already at the table, let us know. And if you don't, let's work together on bringing more of those partners into the group. And if you're a national organization that's not listed, we added the American Association of Community Psychiatrists this past week, bringing us to 54. If you're not listed and would like to be, please let us know. Let's go to the next slide, Karen. Again, we have all of the materials from these calls, the presentations, the quotes, the toolkits, the videos, and the transcripts actually of the chats and texts. You can't see it in this slide, but there are 3 little dots in the lower right underneath the videos that will get you to the transcript as well. So we've tried to keep all of these materials available on the Crisis Talk website. Let's go to the next slide. And I think what we'll do, Stephanie, is let's hold off until we get to the featured presentation, and you can just sort of tee up because this week's Crisis Talk does go into more depth that Tequila Terry is going to bring us in our featured presentation today.
That sounds great.
Next slide, Karen. Tanja Miles, are you with us today? We gave Tanja a moment last week and she was having technical difficulties, but Tanja may not be with us today. So the episode, our latest episode about Tanja's life in the Moving America Soul on Suicide series is available at mesosfilm.com. And we'll have Tanja on another time. She has been really influential in some testimony before Congress recently, and really appreciate her leadership. Next slide, Karen.
Oops.
We're in a open house for a crisis receiving center in Fayetteville, North Carolina on Monday, and Major Robert Ramirez of the Fayetteville Police was in his speech to to the group said, you had me at hello, really talking about this idea of direct law enforcement drop off, where law enforcement can go directly to a facility and not have to visit a hospital ED for medical clearance first. We had a similar crisis meme from Margie on this topic of either last week or the week before. But the question I get a lot is, what is law enforcement's response to this type of an approach? And almost without fail, you get a response somewhere along these lines, where we have defaulted to police in the past and not equipped them with the resources and supports to do this work. And they really, really love when we partner together and take the lead. Next slide. Sarah Corcoran, are you with us to give us the latest update on the tsunami of funding and support around crisis care?
Yeah, and thanks, David. This will be a pretty quick update because last week was more substantive. On the House FY22 appropriations process, they voted that bill out of the full committee last week, and we expect that to be packaged with several other House FY22 appropriations bills, and they plan to vote on that before they go to the August recess. On the Senate side, we've heard that the ranking member Shelby has recently said that they may start to mark up 3 bills before August recess. We don't know if that's going to happen, what bills that might be for FY22, but we'll keep you posted if we hear more movement on the Senate side for FY22 appropriations. On the infrastructure piece, the partisan Senate Democrat package that is going through reconciliation, that $3.5 trillion price tag, we haven't heard much on that recently since the focus this week seems to be on the bipartisan infrastructure framework, which, continuing on today's movie theme, people have started to call BIF for any Back to the Future fans. That is what they've started to package that up as.
That's not good, Sarah.
It's pretty funny to see, I have to say. It takes you back the first time you see it. But they are making progress on that. There's going to be a cloture vote today, which is kind of not really going to actually matter in the long run. They're doing that as more of a, let's see if we can get a package done by today, but they're still working out the details. Some of those bipartisan Senate members have said it could get done as in the details in the writing of the package as soon as today. Some are saying it's going to be more Monday of next week, but they are working out that $600 billion package. And we're also keeping tuned to see what might end up in that larger 3.5 trillion Democrat only package that they've been working out the details on. And that will include the more human infrastructure pieces like we spoke about last week, that home and community-based services piece. So my final plug is, if you have a Democratic senator as your state's representative, or you have 2 of them, showing support for a larger home and community-based services piece of that 3.5 package, showing support for it and why it's necessary is a good idea. That could be whittled down a little bit depending on how that Democrat package works out. So showing support for that is a great idea in the next couple of weeks, so that we can hopefully keep it at that $400 billion level instead of maybe 150 billion, somewhere in that range. So we'll continue to track that and push for the larger number that was floated originally. But as these things kind of work out, keeping the pressure on is important.
Terrific. Thanks so much, Sarah. Do we have an update from either Taylor or Natalie from AFSP?
Hi, all. I do not have an update this week. Thank you, Sarah, for outlining the process forward on appropriations.
Terrific. Thanks, Natalie. Karen, let's go to the next slide. Laura Evans, we've been talking, Angela and Laura and I, about the different ways that both Vibrant and NAMI are trying to track. And we had an approach to the map looking at the legislative changes. I've been using NAMI's map the last few weeks. Laura, you did a great map in the Lifeline Steering Committee meeting last week, and so you've shared that map. Give us a little bit of thoughts on where we're at, Laura, and just the challenges as we're trying to track all this.
Yes, thanks, David. As you know, there's many ways to look at the same information. And so, we want to make sure that we're presenting information that can be easily accessible just by taking a glance without being overwhelming, that still conveys all of the information needed. And so I know Angela and I and you would love feedback either in the comments or via email on how we can present that, what would be most helpful for the JAM. So this map, it focuses exclusively on standalone 988 legislative bills. And so that does not include activities like in Texas, where there was a requirement in their normal budget process for a study. And so that isn't reflected here. These are just the states that had a standalone 988 bill. Legislation in Illinois regarding suicide prevention lifeline on student IDs and other student ID bills weren't included, as well as activities that kind of just didn't pull in all of the elements. But happy to get feedback on what everyone would like to see so that we can make this really informative for you all. On the state level, we're still waiting for New York and Oregon to be presented to their governors for signature. And Massachusetts had a hearing this past Monday in which the Massachusetts Suicide Prevention Coalition put together a panel. NAMI Massachusetts put together a panel. I know MHA Massachusetts has been very critical in the development of this bill. So the bill still remains in committee, but a really great hearing, no opposition that I heard, but would also turn it over to others if they were able to listen in, or if anyone from those coalitions is here.
Angela Kimball, I saw you texting. Anything you would add to this, Angela?
Actually, nothing to add. Laura does such a beautiful job, and I think this map definitely reflects what we're seeing across the country. Just want to thank Vibrant and all our partners for working so hard on state legislation. I will add that we're gearing up for next year and trying to plan more proactively for getting more states further along in the game next year.
Awesome, terrific. Thank you, Laura, and thank you, Angela. Let's go to the next slide, Karen. So for our 5 seconds of crisis calculator, and let's go to the next slide. Tom, I think you were going to make some comments about the planning grants. So we've already referenced today the planning grants that Vibrant has around 988 in crisis care. And of course, we've got the set aside that is both established and growing. And now we have these mobile crisis planning grants. Tom, any reflections on where those stand? Maybe Tom was not able to join us after all. Paul, do you know if Tom was going to be able to join us?
Tom was on with us just a few minutes ago. I don't know if he's there and muted maybe.
David, can you hear me?
Yeah, I hear you now, Tom. Great.
All right, sorry about that. Technical issues here.
No worries.
But obviously there's a number of opportunities in states. We need a scorecard really to be able to track all of the different grant opportunities that states have before them. So you mentioned the mobile response planning grant, $15 million. Letter of intent is due on July 23rd, and the grant applications are due August 13th. So states may, definitely want to be looking at that, availing themselves of this federal funding to be looking at doing their planning around mobile response. That is in conjunction also with the ability to draw down the enhanced match of 85% for that 5-year period. And then David, the other, of course, is the ARPA block grant expansion. And those additional resources plans are due to SAMHSA on July 30th, right? So states are in the midst of finalizing those plans as well. So stakeholders, advocacy organizations involved in crisis and wanting to see states make sure they leverage all these different opportunities are going to be wanting to reach out to different state leaders and make sure that what's in these different grant applications as it relates to supporting 988 in crisis.
Tom, just as you talk, I think there's a couple of deliverables for this call. We've done a lot that's leaned toward a comprehensive view of either legislation or opportunities. The tsunami slide tries to capture everything, but the map that we've just been talking about, tracking through the funding coming from states specifically for 988 and for the extended crisis care, continuing to think through a better way to do that. We've started that conversation. but just a more, you call it a scorecard that looks at the top opportunities and what actionable dates, that kind of thing. Let's talk a little bit more about how we might interject that into this call. There's just, I've been following the text a little bit as well. Some of you are asking about the slides. Normally I do send out the slides, but the content of the featured presentations and most of the key tools, as well as the videos of all this, are on the Crisis Talk website. We are now starting to break Outlook in terms of the mailing list for this call is over 600, and that means that it's taxing hard some of the natural things that we use with Outlook. You can't send an email to 600 people, and unfortunately, we're blasting you. Outlook's hitting you with 15 or 20 invites. So we want to move past all of that, and we're looking right now at making some upgrades to some kind of a more professional platform that will allow us to communicate out this. So going to the Crisis Talk website is the best way to get those resources right now, and expect we're about to make an upgrade that will, again, hopefully clean up this process and make it more user-friendly for all of you. Tom, thanks for continuing to bring attention to these opportunities, and let's work together on that scorecard to track some of this.
That sounds great, David. Thanks.
Great. With that, Karen, let's go to the next slide. I believe that brings us into our featured presentation. And Stephanie, just tee up a little bit, if you would, the conversation you had with Tequila, and then let's have her spend the balance of this time with her partners and her presentation.
Sure. So I spoke with Tequila Terry. She's the Principal Deputy Director of Payment Reform and Provider Alignment at the Health Services Cost Review Commission. Maryland has a unique system where there's an independent agency that regulates the quality and costs of hospital services. And she shared a model that other states might be interested in. It's called the CMS Total Cost of Care model, which is helping to drive and fund innovation in Maryland to expand behavioral health crisis services. And in order to foster innovation, the HSCRC actually developed a regional partnership catalyst program, which included, correct me if I'm wrong, Tequila, but $79.1 million that goes to fund behavioral health crisis services. And we spoke with, you're right, one of the awardees. We did a crisis talk piece interviewing Nikki and Glenn, who helped to put together, they're from the Horizon Foundation. They helped to put together the seed money actually for the Greater Baltimore Regional Integrated Crisis System. And then the other awardees are Total Linking Care and the Tri-County Behavioral Health Engagement. And actually all of the awards went out prior to, or the decision-making happened prior to 988. And so it's been, Terry can talk a little, Tequila can talk a little bit about what the groups are thinking about looking at 988 on the horizon, and how, these are 3 different regions, and how this can actually be integrated possibly throughout the state, and how it's pioneering a lot of change. Tequila, are you on the call?
I am. Good afternoon, everyone. It's nice to see you. Again, my name is Tequila Terry, and I'm delighted to be on the call today. As Stephanie mentioned, I am with the Health Services Cost Review Commission. And so I'm really excited to be able to share with you, give you an overview of the work that we are doing in the state of Maryland, really with the goal of providing, high quality, cost-effective services to our citizens. And so with that being said, if we can move ahead on the slides, I will jump right in. So what I had planned is that I'll talk a little bit about our agency to give you a little context of who we are, and then talked about some of that specific, unique model elements that we have in the state of Maryland that Stephanie alluded to, what we refer to as the Maryland Health Model, that includes a couple of different components and that Stephanie mentioned. And really that is the infrastructure that has allowed us to be able to invest in our regional partnership catalyst program. So I'll share the specifics around that program, how it works, and how it is supporting behavioral health crisis services in the state. And then finally, I'll just wrap up with some next steps and also open it up to our awardees who are also on the line to provide some perspective. So I want to acknowledge Catherine Smith from Tri-County Behavioral Health Engagement, who's on the line, Adrian Bridenstine, who is from GBRICS, or the Greater Baltimore Regional Integrated Crisis System, and then Belina Shaw, who is from Totally Linking Care. So they'll be able to talk more specifically about their work, but I'll talk about the state's effort to be a catalyst in this area and to move things forward. So with that, next slide. So this is just a little bit about our agency. Again, we are the Maryland Health Services Cost Review Commission, or HSCRC. And we are the agency within the state of Maryland that regulates cost and quality of hospitals, ultimately with the goal of enabling Marylanders to have access to high quality care. We are responsible for establishing rates for hospital services with the idea that we are helping to make hospital services more affordable and equitable across the state. We're also very involved in helping the state transform the delivery system and actually achieve the goals that are set forth in the Maryland Health Model, which I'll talk about a little bit more. Just in terms of our structure, we have about 50 staff and 7 commissioners that are appointed by our governor, and that is the decision-making body that plays a role in any sort of policies or programs that we want to launch. Next slide. So I want to talk a little bit about Maryland's unique healthcare payment system because this is really the foundation for all of the work that we are doing now in the Regional Partnership Catalyst Program. So we call it the Maryland Health Model, and it's actually made of 2 distinct components. On the left, the dark blue box, that is what we call the CMS Maryland Agreement. So as Stephanie mentioned, we have this unique agreement with the Centers for Medicare and Medicaid Services. And it is the current agreement is called the Total Cost of Care Model. And what this does is it creates unique incentives for hospitals to transform and focus on quality and ultimately reduce cost in Medicare. So that's one component of our system. The other component is our long-standing all-payer hospital rate setting system. And really what this is a system that we have had really since the 1970s. And it refers to the hospital payment structure that we have in the state, where our agency actually establishes global budgets, including setting rates for hospitals that are used to pay for services across all commercial and government payers in the state. And so under this unique system, the combination, we can make adjustments to the funding of hospitals, really to earmark funds to support state strategic priorities, and to also provide support on work that we as a state need to do to achieve the goals set forth in our agreements with CMS. Those goals are related to cost savings, to care transformation, and to population health. And so as a state, we get a lot of different benefits from this unique health system. It enables us to control costs for the public because we've got everyone, all the payers paying the same thing for services within the hospital, same rates. So we don't see that the cost shifting that exists in many states. So a much more equitable system. We also fund uncompensated care. It's built into the payments to hospitals. So every hospital across the state can see folks regardless of the insurance that they have. And it creates stability, which was really important in these times, in particular under the COVID pandemic, where many healthcare resources that are on a traditional fee-for-service payment model struggled as volumes declined when people stopped going into hospitals during the crisis. And so here we have been able to use this system to, among other things, stabilize. What I'm going to focus on in particular is this next bullet, is that it funds investments in population health. So this is one of the core elements for how we have been able to use this system to be able to support behavioral health crisis services in our state through this program. Next slide. So just a little bit more about the agreements that we have with CMS. So on the left side, we started working with CMS in about 2014 on what was called the all-payer model. And essentially what that did was create a structure under which we moved hospitals out of a fee-for-system service into a global budget service or population-based budgets, basically as a way to better manage hospital costs and to ensure that rather than incentivizing more people going to hospitals, really getting people placed in more appropriate settings. So fast forward, we then in 2019 launched a new agreement with CMS called the Total Cost of Care model. And here, the model actually encouraged us to focus not just on hospitals and what hospitals could do to increase quality and reduce costs, but really to focus on, across the system, how can we improve cost, quality, and now population health. This idea of focusing on population health in particular allows us to encourage hospitals and all of the resources across the state really to coordinate to address those conditions that are so very chronic and prevalent in our state. And when we started looking at what conditions, what issues we wanted to solve for, certainly behavioral health crisis services rose to the top. So that's a little history about how we came to this point. Next slide. In 2019, there was one additional nudge, so to speak, from the CMS folks to say population health is really, really important, and we want you to be very specific to focus on key issues in your state. We established what's called the Statewide Integrated Health Improvement Strategy. And what this strategy did was create an additional MOU, Memorandum of Understanding, with CMS to say that the state of Maryland is going to work on these three domains. We're going to work on improving hospital quality, avoidable admissions, improving readmissions. We're going to foster care transformation across the system by increasing the number of value-based care models that we have in the state and improving care coordination. And then most notable for today's discussion, we started focusing on population health and really specific goals that we wanted to address in the state. And so diabetes was a condition that rose to the top as we started thinking about what are the key conditions we want to address. So that's priority area number one. Priority area number two was the opioid crisis. And really the fact that Maryland had been grappling with opioids across a number of years. And so we wanted to focus on improving overdose mortality. And then finally, maternal and child health. But it was this focus on, again, population health and really looking at the key areas that the state was working to address, making sure that we were focusing on what we could do to improve the incidence and prevalence of these conditions that really led to us looking at behavioral health crisis services. It's notable that the opioid crisis in particular was identified as a statewide priority through the highest levels of leadership, through our lieutenant governor, and then a state of emergency was declared by our governor, Governor Hogan, in 2017. So this one in particular grabbed the attention of leadership and really led us to say, what can we do to address it? So next slide. So what Given those priorities coming from the federal government and this desire for us as a state under this total cost of care model to focus on population health and very specifically on those health priority areas, that is where the Regional Partnership Catalyst Program was really born. Next slide. So what our agency did was really to start thinking about how we could leverage our unique system and the ability to earmark funds through this hospital rate setting system, really as a way to invest in hospital partnerships with community organizations so that they could build programs that ultimately helped us achieve those population health goals and the total cost of care model in a way that would be sustainable over time. And so, as I mentioned, there were a number of priorities in that population health area of our statewide strategy. But in particular, that second funding stream, behavioral health crisis services, was really a direct connection to addressing that area of the statewide integrated health improvement strategy. And it was our goal to support the implementation or expansion of behavioral health crisis services infrastructure. We knew that that had to be a significant investment to ultimately achieve some of the other cost savings and quality goals that we had with the federal government. So this program just launched earlier this year, January 1st, and it'll run through December 31st, 2025. And across all of these funding streams, we have invested $165 million. But to Stephanie's point, in behavioral health in particular, it's $79.1 million. So a significant investment over the next 5 years. Next slide. So what exactly are these hospitals going to be doing is a question that we get often. Really, the idea behind this Regional Partnership Catalyst Program was to create funding so that hospitals could work with communities to build programs that align with the Crisis Now model. And so when we were doing sort of a scan of what are the opportunities to improve crisis services, we really were referred to this model by a number of different individuals who said, if you really want to address, this issue of people presenting at hospital emergency departments, you have to understand that there needs to be somewhere else for them to go and a system that provides support. And so you all are very familiar with the model, but the regional partnership awardees have been asked to use this framework as a starting point because one, we knew it was evidence-based. We know that other states have adopted elements of the model and it's working. So that was important for us, that there was something that we could point to that demonstrated that this could actually result in better outcomes for people. It was also important to us to make sure that this would be a way to create interventions that would reduce unnecessary emergency department and hospital utilization, which is one of the metrics that we have under our agreement with CMS. So again, that agreement with CMS was really quite an impetus for our work. And then finally, we also recognized that it was important to address gaps in capacity. And so this model allows folks who receive the awards to work on the crisis call centers, really that idea of creating technology for real-time coordination across the system and using big data to really understand how the system is performing. And making sure that we have a way to provide a high-touch system to individuals or families that are in crisis. The mobile crisis services, really recognizing that we have to have a model that offers outreach and support to locations where individuals are actually experiencing crisis, right? So we have to move upstream. We can't wait till they present in hospitals. And then finally, crisis stabilization. really this idea of short-term subacute care for individuals who needed support and observation, but not relying on ED holds or medical inpatient stays, and doing it in a way that was more cost effective. So these were the parameters we set forth when we released our request for proposals out to hospitals. Next slide. So just a note about collaboration. So when we requested proposals from hospitals, what we did was say, this money is going to be available, but you're only eligible if you are going to work with members of your community, and your proposal must articulate how you're going to bring together a diverse set of hospital and community resources that ultimately can have an effect on the state's goals in these areas, in this instance, behavioral health crisis services. And so what we ended up getting was far more than what we had ever imagined. We had 30 plus hospitals across the state come together in various forms to work on crisis services. And they brought with them 150 plus community partners, everyone from health departments, nonprofits, faith-based organizations, law enforcement, social services. So it was, it was so critical to us that we built this in a way that, it was intended to be this groundswell of activity, working with the hospitals and community resources. And again, the hospitals went above and beyond to extend invitations and collaboration opportunities. And then we also made a point to say that we want hospitals to have meaningful community partnerships. So establishing a framework for what that actually meant. So resource sharing, direct payment, in-kind support, because we want the community to be able to continue working with the hospitals over time. Next slide. So just real quickly, when we got all these proposals in, we had an evaluation committee that looked at a lot of different areas of the healthcare system, had varying degrees of expertise. We actually had Dr. Hepburn as one of our subject matter experts and a non-voting advisor, because we knew we needed some expertise to be able to sort of pick out what are the best proposals to fund. And we used this criteria that you see here. I won't read all of this, but it was important to make sure that we were looking at all of these elements to identify what are the proposals that have the greatest likelihood of success. And it was a very difficult decision, frankly, because we had so much interest. We had, I want to say, over $100 million more in requests than we could actually fund. So we had to be very mindful of, our budget and what our resources could do, looking at these key evaluation criteria. Next slide. And so in the end, we ultimately supported 3 regional behavioral health proposals that reflect different areas of the state, that include, again, the GBRICS, TLC, and Tribe regional partnerships. And you can see here sort of the diverse number of hospitals. Some of the jurisdictions are urban, some are rural, so their partnership mix is a reflection of that. And you can see the investment is significant across all 3. Next slide. So as we move forward, one of the things that was really important to us is to make sure that we have some specific scale targets or impact measures that we could use to assess the effectiveness of our funding. What we laid out was a plan in our request for proposal documents that identified the specific targets that we are going to be measuring over the coming years to ensure that these programs are optimized and working as we had envisioned. So it's everything from, planning and development, documentation, up to boarding time measurement at hospitals, Ultimately, we want to decrease that. And then addressing repeat utilization of ED for behavioral health conditions. And so these are really all a part of the work that we envision we would do to ensure that these programs were working as envisioned. Next slide. So just in closing, I want to say that, this is a program that we're incredibly excited about. We believe the Regional Partnership Catalyst Grant Program actually offers a significant opportunity to support statewide population health activities, to support our agreement with CMS, and ultimately to make a difference in the lives of the people who need these services. And so we're really excited about the potential. From our standpoint as a state agency, as we move forward, we're going to be monitoring the progress. So we're actually in the midst of doing sort of mid-year check-ins with the partnerships, really to understand, for example, how COVID has impacted their plans and how the community is being incorporated. And to the earlier point, how they're aligning with now the new 988 structure. And then we'll also be looking at additional opportunities to improve infrastructure. So this is one piece of the puzzle for our state. But through our Maryland Department of Health, Behavioral Health Administration, we are wanting to be in lockstep with how this affects the statewide planning. And so being a part of that state planning on crisis services and being engaged in looking at the long-term plans for the state. And so I'll stop there. And I don't know, David, if we want to give our partners an opportunity to chat or how you want to handle.
Yeah, Tequila, this is terrific. And I love seeing the fully integrated model and an approach that's so innovative and really speaking to just such key issues that are challenges across the country around uncompensated care and around the integration of population health. But let's go to the next slide. Tequila did reference a key partner from each of those. And we've got just a little less than 5 minutes left. So maybe we can just get a minute apiece. Catherine, if we could start with you with Tri-County.
Good afternoon. Catherine had to drop off the call. I'm Tina Simmons, her counterpart from Atlantic General Hospital. But both our primary and secondary sites are on target to open in January. And in our developmental phase, we have experienced tremendous collaboration with our community partners, and it's really driving a lot of what we do outside of the Crisis Stabilization Center. So it's been a wonderful opportunity for us.
Terrific. Thanks so much for joining us. Adrian Bridenstine. Adrian, you've been a routine participant, and tell us a little bit about the GBRICS. And we've heard some about that already, but a little bit more.
Having us. I'm Adrian Bridenstine. I'm with Behavioral Health System Baltimore. For those who don't know us, we're a nonprofit and we serve as a local behavioral health authority for Baltimore City. For this project, the GBRICS project is the one that cuts across 4 jurisdictions in the central Maryland area. The one thing I'll add to what Tequila said about the collaboration is that the Regional Partnership Catalyst Grant is really an opportunity to bring behavioral health, the behavioral health sector and the hospital sector in a really intentional way around high-level system reform goals, which is not something that's happened in the state of Maryland before. We've been working together for years and years, but not at this kind of system level. So I think that's a great advantage of this project. But quickly, we're looking to implement certain components of the Crisis Now model, the care traffic control infrastructure, creating a regional centralized call center that's supported by that infrastructure, and then really expand our mobile crisis services across the region so that we can be more responsive to the needs.
Wow, just terrific. And look, the intentionality around actually impacting psychiatric boarding and hospital presentations that are not necessary is just terrific. Belina Shaw, also a regular participant. Tell us a little bit about the third initiative funded by Tequila and her team.
Sure. Thanks to be here. So Dr. Belina Shaw, the medical director for the Behavioral Health Division at the Prince George's County Health Department. So as Tequila mentioned, these partnerships are truly partnerships, and we are thankful at the health department to be able to be so intimately engaged in this project that the hospitals have received the money for. So our project is a conglomerate of the elements as well, with the air traffic control software, a tech-enabled case management system so that we can capture those high utilizers and really impact those scale targets in the final couple of years. But we'll be doing that throughout the whole project. Also focusing on transportation, mobile crisis expansion, and a stabilization center, which will be a new project for us, especially the stabilization center. A shameless plug that we will be releasing the RFP for that very shortly. So please stay tuned for that. I think we'll be able to disseminate that in the ways that we've done in the past. And just as we're talking before about leveraging 988, one of our exciting new developments is that the organization that will be doing the mobile crisis team expansion component of this work is also the lifeline provider for the region that happens to be located in our county. And so we're really looking at the ability to divert upstream and really use those resources for the least restrictive resources with that connection.
Elena, thank you so much. And Tequila, thanks for joining us today. This is really terrific work that you and your team are I use the word catalyzing. That's exactly what's happening. John Palmieri, do you want to give us some wrap-up comments and reflections for today's call? John, are you still with us? Saw John a second ago. He may have just dropped off. Brian, do you want to close us out? So people may be jumping off. Tequila, thank you so much. Really terrific work. And we'll continue to look for updates, especially as you're tracking through to the impacts and outcomes associated with this. Thanks to everybody. Karen, if we can go through there are some appendix slides that we will include, but Karen, if you can go through the pipeline and we'll end there. Next week, we have Dr. Eric Raflawan, has really received some national recognition around the work he's doing up against race, equity, and mental health crisis care, with Wendy Tygreen following up with more detail around the terrific presentation she did on peer supports a couple of months ago now, the week after. So we hope to see you all next week. Thanks so much for joining.